So it is really a pleasure for me to introduce Dr. Blitshteyn and Svetlana, who is the director and founder of this Autonomic clinic. I was just talking to her, and I'm so happy to have a person like her in Buffalo, because most of us as a neurologist, we really do not, we know the basics, but we do not know how to really investigate very good. So we have to, I'm very happy to have a person like her in the city of Buffalo. So her major area of interest is autonomic disorder, and give consult and on POTS, neurocardiogenic syncope, small fiber neuropathy, and variety of other ones that she will be. She's currently assistant professor at the University of Buffalo, and her training in neurology was at Mayo Clinic, but her MD was from University of Buffalo. She's a member of American Academy of Neurology, American Autonomic Society, and NERS, and on medical advisory board for this Autonomia International, also this Autonomia Information Network, and Ehlers-Danlos Society. She has been invited as a speaker in many national and international conferences, including World Health Organization, and she has been principal investigator in several studies, including POTS and autoimmunity, POTS and pregnancy, and POTS vitamin deficiency, and few others. She has co-authored a patient book, a very interesting one, as you see its name over there. And she has been interviewed by a variety of media outlets, including US News, World Report, Medscape, Neurology Today, New Scientist, and some others. And she has had multiple awards, including Patient's Choice Award in 2019 from this Autonomia Support Group, and also Business First 40 Under 40 Award, Mayo Clinic Neurology Research Award, and American Headache Society, and the US Human Health Award. So it is, before she starts talking, I just remind you, next week we're going to have the new director of CHS Cardiology, Dr. Mohan, and then Dr. Margaret Prarsky, who also is a chief medical officer for Catholic Medical Partner, talk on dementia, and Dr. Steve Kubowski will be talking on violence in America. Actually, it's going to be a very good topic, especially with this situation. So I'm going to stop sharing, and then I'll let Svetlana to.
Okay, excellent. Thank you, Dr. Sami, for inviting me to speak at the Grand Rounds this morning, and thank you for this introduction. I'm honored to be among your great speakers you've assembled. I'm looking forward to their lectures in the next few weeks. So I'm a neurologist specializing in autonomic disorders. In my dysautonomia clinic, I see patients with all types of autonomic disorders, most common being small fiber neuropathy, orthostatic hypotension, and postural tachycardia syndrome. The topic today is autonomic disorders in clinical practice. We will review the autonomic nervous system, autonomic function tests, and clinical features, and also will review treatment of common autonomic disorders. For the residents here, please consider going into autonomic disorders as a specialty. Autonomic disorders is a hybrid field that overlaps with cardiology, internal medicine, immunology, and rheumatology. So if you are like me and enjoy a little bit of everything, this might be the field for you. And I promise you will never be bored. We will start with a case presentation of my current patient. She is a 38-year-old nurse practitioner with a 5-year history of fatigue, dizziness, palpitations, recurrent syncope. Now she's unable to work. Her past medical history is remarkable for asthma, allergies, 3 concussions when she was younger, kidney stones, and hernia repair. Her course involved these recurrent, what was labeled as viral illnesses, but really she had recurrent dehydration, dizziness and required IV fluids in the emergency room. She's also had a confirmed C. diff colitis multiple times at age 38 without antibiotics that preceded these episodes. She's had progressive course of fatigue, generalized weakness, and orthostatic intolerance over the years, and that's despite using different medications for her orthostatic intolerance. Her physical exam was remarkable for postural tachycardia and a stand test with orthostatic symptoms. And her motor and sensory exams were unrevealing. EMG, MRI of the brain, and MRI of the cervical spine were all unremarkable. A skin biopsy, which was obtained from distal leg and proximal leg of the thigh, showed borderline reduced epidermal nerve fiber density at the distal leg. Her tilt-table test was positive for POTS. She also had a number of cardiac tests, which were all unremarkable. And her blood tests revealed elevated ANA, 5 times normal, elevated CRP, and SED rate. All other autoimmune markers, including Sjogren's antibodies, were negative. So another diagnostic test was performed. Which one? You're welcome to speak or put this in the chat box. If anybody wants to do that. Of course, I'm not, okay. Maybe I'm...
Anyone do a CAT scan?
I'm sorry?
Anyone do a CAT scan?
Of?
A CTA of her brain? You did an MRI?
Yes, unremarkable. Here we have some, in the chat box, we have someone say plasma renin activity. Okay, yes, good. LP, sure, would be very informative. Okay, anyone else wants to contribute?
If anybody wants to speak, you have to unmute your...
ANCA, someone said ANCA. Yep, very good, unremarkable. LP, LP was done, negative. That was not the diagnostic test, but also very good ideas here. Okay, so we'll go on. What is her diagnosis? Well, we know she has POTS because we diagnosed it on a tilt-table test, and her stand test at the doctor's office showed postural tachycardia associated with dizziness. Does she have small fiber neuropathy? Because her skin biopsy showed borderline reduced epidermal nerve fiber density at the leg. She has no neuropathic pain. Some doctors felt she qualifies for this broad umbrella term with very little meaning, in my opinion, chronic fatigue syndrome. Other doctors suggested that she has generalized anxiety disorder, major depression, and a neurologist thought she may have functional neurologic disorder, aka conversion disorder. A cardiologist felt she may have deconditioning. She's been lying down a lot because of orthostatic intolerance. She hasn't been exercising. Can this be deconditioning? And we also have suggestion that she has some kind of autoimmune disorder, but she has no joint pain, no joint swelling, no rashes, and no other features of autoimmune disorder because her antibodies for specific disorders were all negative. So I requested a minor salivary gland biopsy, which was sent to Hopkins Sjogren's Center. If any of you remember Alan Baer, Dr. Alan Baer, who was a rheumatologist at ECMC years ago, he is now at Hopkins Sjogren's Clinic as one of the specialists who is reading biopsies. He looked at my patient's biopsy and found focal sialadenitis with a focus score of 1. And this is diagnostic of Sjogren's syndrome. But as you recall, her Sjogren's antibodies were negative. And this is not uncommon since negative serum antibodies are found in at least 60% of patients with Sjogren's syndrome, especially in those who present with neurologic complications. So the diagnosis is spots with autoimmune markers, or another name for it, autoimmune dysautonomia, secondary to Sjogren's syndrome. Let's define terminology. Dysautonomia is a general term used for any autonomic disorders or impairment. Sort of like we say headache without defining the type of headache. And autonomic neuropathy refers to dysfunction of the peripheral autonomic nerves. Small fiber neuropathy is one type, and it's not the same as autonomic neuropathy. We'll discuss that soon. Common autonomic disorders are postural tachycardia syndrome, neurocardiogenic syncope, and neurogenic orthostatic hypotension, and you're all seeing this in your practice. And then we have less common disorders, multiple system atrophy, pure autonomic failure, autoimmune autonomic ganglionopathy. We're seeing that in our neurology clinics. Rare autonomic disorders include familial dysautonomia, which is a hereditary disorder, most common in Ashkenazi Jews. It's an autosomal recessive disorder, and amyloidosis. And you will have we'll have a talk next week about amyloidosis. What is the autonomic nervous system? It's an output system that controls visceral functions. As you all know, it consists of sympathetic, parasympathetic, and enteric nervous system. The autonomic output is triggered by two main stimuli, sensory one from visceral or somatic receptors, and the second one is inputs from the brain. So we have a input from the body and input from the brain, areas that are involved in homeostasis, emotions, and stress responses. We'll just quickly review the functions of the autonomic nervous system. You all remember them from training. The sympathetic system is critical for maintenance of blood pressure, regulation of blood flow, thermoregulation, and response to stress, metabolic, emotional, and exercise. And your parasympathetic output is critical for your heart rate control, heart rate variability beat to beat, and motility of esophagus and stomach. It's a secretory system, so it's responsible for micturition, salivation, lacrimation. It's also responsible for erectile functions, and it causes pupillary constriction. And the enteric nervous system is needed for motility and secretion of the gut and defecation. Let's remind ourselves the basic pathways of the autonomic nervous system. As you recall, the sympathetic system is located in the thoracolumbar region, with the first neuron being short, and its synapses on the perivertebral sympathetic ganglia right here. The long neuron, the second neuron, innervates the end organ, and its synapses on the end organ. Note that acetylcholine is used on the preganglionic synapse and norepinephrine at the postganglionic. So just basic science here. The parasympathetic is the craniosacral system, with the first neuron being long, as you see here, and its synapses on the end organ ganglia. Here is your vagus nerve, very important, innervating heart and abdominal organs. And this system uses acetylcholine pre and post-ganglionic. Centrally in the brain, as you see, the pathways are quite complex, but let's emphasize the anterior cingulate gyrus and insular cortex right here, which are important in behavioral arousal, painful stimuli awareness, emotions, stress response, and homeostasis. We follow the pathway down through the hypothalamus and amygdala and the midbrain down to the medulla, which has three important nuclei of the vagus: the dorsal motor nucleus of the vagus, nucleus ambiguus, and nucleus tractus solitarius. As you see from this drawing, if a patient has lateral medullary infarction that affects these nuclei or tracts, these patients can have dysregulation of blood pressure and all autonomic functions as part of central dysautonomia. These are your respiratory reflexes and autonomic reflexes that control the autonomic nervous system from the brain. Which leads us to central autonomic disorders that can be divided into degenerative, traumatic, and hereditary. Central autonomic disorders in the neurodegenerative category involve your MSA, PAF, dementia with Lewy body disease, and Parkinson's disease, although in Parkinson, the dysautonomia is milder than in MSA and pure autonomic failure. Traumatic category includes dysautonomia from traumatic brain injury or concussion and spinal cord injury, and hereditary types, your mitochondrial disorders and Fragile X tremor ataxia syndrome. Peripheral autonomic disorders are numerous and can be due to metabolic, toxic, hereditary, autoimmune, inflammatory, and immunologic and post-infectious causes. In the metabolic, as you see here, diabetes, the most common one, and vitamin B12 deficiency, we test for that. As you go down the list, you also see alcohol. Alcohol is a very common cause of neuropathy in the world, diabetes in the United States. Chemotherapy is common. Sometimes you see patients who were treated with chemotherapy for cancer, and they present to you not necessarily with pain and burning pain in the feet. They can also present to you with autonomic disorders. On the slide, we see the continuation of the peripheral autonomic disorders, and you see all of your autoimmune disorders. They can be associated with dysautonomia, peripheral dysautonomia. Sjogren's syndrome is on this list. And as we learned, is the second common cause of small fiber neuropathy also in the United States. But you also see your inflammatory bowel disease category, which means you may have a patient with Crohn's or ulcerative colitis who presents to you with symptoms of dysautonomia, lightheadedness, dizziness, orthostatic intolerance, fatigue, and exercise intolerance. In the immunologic category, there is common variable immunodeficiency, selective immunodeficiency, mast cell disorders. We'll talk about that at the end. And in the infectious, post-infectious category, there are all of your post-viral, EBV, CMV. There is Lyme here. And now I think we need to add COVID-19 because I am seeing some patients post-COVID with autonomic disorders. There are also autonomic disorders of sweating, GI, and GU system, but we will not go into details on these disorders. We'll talk about sweat disorders shortly. Here you see some representations, drawings from a thermoregulatory sweat test. You see the sweat pattern. This is your peripheral neuropathy pattern, and this is the central found in MSA and pure autonomic failure, and this is your patchy kind associated with autoimmune disorders, and also you can have that in postural tachycardia syndrome. How do we measure the autonomic nervous system? By performing autonomic function tests. The standard laboratory testing evaluates cardiovagal, which we just saw, meaning the parasympathetic input to the heart, sudomotor, which is your sweat response, and adrenergic function. Cardiovagal function is evaluated by testing heart rate response to deep breathing at a defined rate and to the Valsalva maneuver. And pseudomotor function is evaluated by QSART, or quantitative pseudomotor action reflex test, and thermoregulatory sweat test, which is a sweat box. Adrenergic function is assessed by blood pressure and heart rate response to Valsalva and the tilt table test. And here you see this is the autonomic testing and equipment, and this is your tilt table test. No patient is there yet. In this table, we see different autonomic function tests, many of which were developed at Mayo Clinic. QSART, TST, both of these tests help us localize the lesion, whether the lesion is preganglionic or postganglionic. Localizing the lesion is very important in neurology because that's how we figure where the problem is. HRV, or heart rate variability, tests the vagal efferents and afferents pathways of parasympathetic system. Here's your Valsalva ratio, very important. Blood pressure response to Valsalva is an adrenergic function. Here's your tilt table test, we'll talk about that. And then we also have serum plasma, norepinephrine, supine and standing, that helps us understand if the patient has hyperadrenergic response. And the cardiac scan can be done to assess the postganglionic innervation of the heart. So what information can be gathered from the autonomic function tests? As I said before, it provides a localization. If we have access to all these beautiful tests, we can say if the lesion is pre or postganglionic by using the QSART and TST. The autonomic function tests also identify which branches of the autonomic nervous system are affected. And it suggests differential diagnosis and workup when we use all three tests. And the tilt table test helps us figure out if the patient has syncope, orthostatic hypotension, or POTS on the tilt table test. The thermoregulatory sweat test is a fun test which uses a sweat chamber with infrared heat lamps that heats the body to oral temperature, or 38 degrees Celsius, whichever comes first. The body is covered with alizarin S powder, which turns the color from yellow to purple on coming in contact with sweat. Here you see a sweat box, that's real. And then you have different sweat patterns on a person, and then the drawing. And it's important to mention that in this global anhydrosis, as you see here, the person is not producing any sweat, the body is covered in yellow. This is the kind of pattern you see in neurodegenerative disorders, such as multiple system atrophy and pure autonomic failure. Ironically, you see some sweat in the hands and feet. That's one pattern. The second common pattern is your peripheral neuropathy. You see the body sweats. This is normal, turning from yellow to purple, meaning that your sweat is being produced. The feet are not sweating at all, they're yellow. The face may also, remain, but typically you don't have much sweat glands on the face. This pattern is common with small fiber neuropathy, peripheral neuropathy. You see this patchy pattern. Some areas are yellow, some are purple. And this occurs in autoimmune disorders, mainly autoimmune autonomic ganglionopathy, which we'll talk about later, and also autonomic neuropathies associated with Sjogren's, lupus, rheumatoid arthritis. Why are the autonomic tests needed to begin with? Well, to summarize, it examines the presence or absence of the autonomic fibers involvement. At Mayo Clinic and other labs in the country, a grading system called Composite Autonomic Scoring Scale, or CAS system, is used to grade the extent of the autonomic failure. As you see from this figure, MSA, multiple system atrophy, pure autonomic failure, they have high scores, while peripheral neuropathy and Parkinson's disease type of autonomic dysfunction has lower scores, so less autonomic involvement. Autonomic neuropathy, if present in a diabetic patient, marks a poor prognosis. At least 50% mortality in the next 5 years. So autonomic neuropathy in diabetes is usually bad news. What if the autonomic tests are not available to us? And they're not available in Buffalo. We have to make the best with what we've got, and we have many tests available to us locally. We have a tilt table test, widely available. We can do a skin biopsy to evaluate for small fiber neuropathy. We can get EMG to rule out large fiber neuropathy, CIDP, myasthenia. We can do blood and urine tests that are important in evaluation. We can get cardiac tests done, Holter monitor, event monitor, cardiac echo, and stress test. We also should think about Sjogren's in a young woman or a middle-aged woman presenting with typical features. And as you could see, the antibodies may be negative, so get a lip biopsy done. A fat PET biopsy is done to rule out amyloidosis. We do that here at Roswell Park. We can get gastric emptying tests to see if there is gastric motility disorders that are very common in our patients. Urodynamic studies can show whether the patient has neurogenic bladder. A sleep study is very important to rule out central sleep apnea and other sleep problems that are very common in our patients as well. How do we diagnose autonomic disorders? In the same way we diagnose many neurologic conditions. We have to rely on detailed history and exam findings. One needs to be on the lookout for the history of orthostatic intolerance and other autonomic symptoms. And that typically is temperature dysregulation, neuropathic pain, exercise intolerance, and fatigue. On physical exam, you look for signs of dryness, since dehydration is a common feature in dysautonomia. Dehydration and low blood volume are important mechanisms. And then you can look at acrocyanosis. What's that? Here you see a photo of a normal healthy person standing for 5 minutes. And here you see a patient with spots standing up for 5 minutes. You see the difference in color. Purple-blue discoloration of the feet is called acrocyanosis and can be a helpful sign for us to look for. We can also do orthostatic blood pressure and heart rate in your office. And now in this time of social distancing, a 10-minute self-administered stand test performed by the patient is a fair assessment of their orthostatic vital signs. So you can even ask them to do that when you do telemedicine. On neurologic exam, we look for dilated pupils, atonic pupils. Is the patient areflexic? Are there any sensory exam findings like loss of temperature and pain sensations in a length-dependent pattern? Very importantly, we look for signs of Parkinsonism. Is there ataxia or steady gait for us to see if the patient may have neurodegenerative autonomic disorders such as multiple system atrophy or pure autonomic failure. A skin biopsy is an easy test that you can do in your clinic. It takes about 10 to 15 minutes to complete. Companies like TheraPath and others provide free testing kits which utilize a punch biopsy device to remove a piece of skin from behind the ankle and at the thigh. The samples are sent to pathology for epidermal nerve fiber density and sweat gland density assessment. They use immunohistochemistry and staining to the antibody that's present in axonal protein. You can also request Congo red stain to rule out amyloidosis. So what is small fiber neuropathy? As you recall from neuroanatomy, small, thinly myelinated, alpha delta fibers and unmyelinated C fibers enter the spinal cord at the lateral zone, and they cross to the opposite side, and they cross in the anterior commissure, and then they ascend to the thalamus in the anterolateral system. These fibers carry temperature and pain sensation from the body, unlike the big myelinated fibers that carry proprioception, vibration, touch. Small fiber neuropathy cannot be diagnosed by EMG. It's very important we say that, because oftentimes physicians order EMG, it comes back negative. Automatically we think rule out neuropathy. We have not ruled out small fiber neuropathy. Usually EMG and sensory conduction studies are normal in patients with small fiber neuropathy. We need to do either QSART if it's available. If not, we can also refer them to the Autonomic lab, or we can do a skin biopsy that we just talked about. Small fiber neuropathy is not the same as autonomic neuropathy, because autonomic neuropathy is a subset of small fiber neuropathy. The symptoms of neuropathic pain are very common. You all know them. It's the burning pain, numbness, tingling, shooting, heavy itching. Sometimes itching is this unusual symptom of peripheral neuropathy. Extremities can be cold, and sometimes there are no neuropathic pain symptoms, yet the patient still has evidence of small fiber neuropathy on tests. Signs of small fiber neuropathy is loss of temperature and pain sensation in a length-dependent pattern. Usually that's in diabetes and vitamin deficiency, but you may also have patchy loss or non-length dependent, and that's common in autoimmune disorders and also common in Lyme disease. It doesn't follow the usual pattern of length-dependent involvement. 50% of what is labeled as fibromyalgia is actually small fiber neuropathy. And 50% of our patients with spots have small fiber neuropathy. There are numerous causes of small fiber neuropathy, as you see from this long table. But let's review that diabetes and glucose intolerance are the most common causes of small fiber neuropathy in the United States. Sjogren's, as you see here, is the second most common. You need to have a high clinical suspicion for Sjogren's, easily misdiagnosed with chronic fatigue syndrome, fibromyalgia, you name it. Functional neurologic disorders, can the patient just be depressed and not move? But you need to suspect it so that you can press further. Of course, when you have the positive markers of autoimmunity, non-specific ANA, rheumatoid factor, CRP, cedrate, really suspect Sjogren's or another autoimmune disorder, and as in the case of our patient, obtain a lip biopsy, which is the gold standard. From this table, you see obviously also nutritional deficiency is very common. I always test for B12, B6, B1. And as you recall, B6 is one of the vitamins that can cause neuropathy when it's deficient, and also neuropathy when there is a toxic level. So an excess and a deficiency of B6 can cause neuropathy and neuropathic symptoms. Celiac disease, Lyme disease, Fabry's disease, alcohol abuse, and drug exposure is also very common. Essentially, whatever you think of peripheral neuropathy, there is more than can cause small fiber neuropathy because they're more susceptible to damage than large fibers. Treatment of small fiber neuropathy is symptomatic with neuropathic pain medications. This is your gabapentin, Lyrica, amitriptyline, and others. We also have topical medications, lidocaine, capsaicin, other creams compounded that can be done. Neuromodulation, TENS unit, and non-invasive vagus nerve stimulator are coming up as also very important. But of course, if you find the underlying cause of neuropathy, treat the underlying cause. In the case of diabetes and glucose intolerance, this would be your glycemic control. If you find vitamin deficiency, you need to correct that. And diet can be sometimes very helpful, not only for diabetes, but for patients who may have this gluten sensitivity. These are not your celiac disease patients. They're people who are sensitive to gluten. They have a lot of GI symptoms. Yes, it's real. They may have autoimmune markers. And if they go on gluten-free diet, they actually improve. The number one symptom they tell me improves for them is the GI dysfunction. A lot of the times, abdominal pain, nausea, diarrhea, constipation, IBS-like symptoms will improve. Sometimes neuropathy also improves, and joint pain is also a big symptom that can be improved by gluten-free diet. A lot of the times the cause is unknown, at least 30%. We suspect this may be immunologic type of etiology because a lot of the times there are antibodies that are circulating and may result in small fiber neuropathy. There are many antibodies that are identified, but there are also many antibodies that are presumed and not yet clearly defined. So immunotherapy is coming out as a very important tool. Not widely available, but we are using it. We will talk briefly about autoimmune autonomic ganglionopathy, or AAG, and it's a rare type of autonomic neuropathy that involves ganglionic acetylcholine receptor antibodies. As you see here, if you have these antibodies, they block both sympathetic and parasympathetic ganglionic transmission, resulting in significant autonomic failure. I also like this diagram because it nicely shows various adrenergic and muscarinic receptors that are important in quite a few autonomic disorders, may actually be biomarkers in the future. For example, we have several good studies that show elevated alpha-1 adrenergic receptor antibody and beta-1 adrenergic receptor antibody in the heart, as well as muscarinic cholinergic antibodies in patients with SPOTS, small fiber neuropathy, and complex regional pain syndrome. So these antibodies, remember them because we hope to have diagnostic tests available very soon. We already have research tests, that's how we do research. And there are commercially available tests in Europe that are testing for these already. In our country, we don't have that available yet. AAG typically presents in midlife with an average age of 50 years old, and it usually commonly follows a viral prodrome. At least 70% of patients present with orthostatic hypotension and GI hypomotility with severe constipation. 25% have neuropathic symptoms. Notice, they may not present with neuropathic pain, and that does not rule out autonomic neuropathy or even small fiber neuropathy. Motor exam is usually normal in these patients, which differentiates them from Guillain-Barré syndrome. And that's very important. They come to the ER just like Guillain-Barré syndrome, except their exam is very different. They have normal strength, reflexes, and nerve conduction studies. Yet they have a variant of the syndrome. Some people feel AAG is a variant, but it's its own disorder because the key feature is elevated ganglionic acetylcholine receptor antibody. It's very important. Think of that antibody. You can get it through Quest. You can also get it as part of the perineoplastic or autoimmune dysautonomia panel that you can send off to Mayo Clinic Rochester lab. Of course, to make things harder on all of us, there are also forms of AAG with negative antibodies, negative acetylcholine receptor antibodies. So if you see this clinical picture and you think it could be AAG, but the acetylcholine receptor antibody is negative, do not rule this out. This only means that unidentified antibodies to the autonomic ganglia may be at play, and we have to identify these antibodies in the future. A tilt-table test is always available to us and is essential to diagnosing autonomic disorders. Here you see the tilt-table test. You lay down a patient for 3 minutes. You monitor their heart rate and blood pressure continuously, and then you simply tilt them to 70 degrees for 10 minutes, sometimes to 40 minutes or until syncope occurs. That's what the cardiologists use. In neurologists, we're not that mean. So 10 minutes is enough for us to see the pattern. And you observe not only the vital signs, but also the symptoms that they experience. And it's going to be important whether there are symptoms or if they are asymptomatic. And then they are returned to the supine position with their heart rate and blood pressure still monitored at baseline. So I'm going to show some patterns, some common patterns that you see on the tilt-table test. This is a pattern for neurogenic orthostatic hypotension. As you see here, when the patient is tilted, you see a slow decrease in blood pressure, and the heart rate is not increasing, and that's not normal. Normally, when your blood pressure drops, your heart rate needs to increase to keep the perfusion going. Here you see a decline, okay? And this is a pattern of neurogenic orthostatic hypotension. When they are returned to the supine position, the vital signs normal. This is a pattern of vasodepressor syncope, also known as neurocardiogenic syncope. You see the patient is tilted, heart rate, blood pressure are all stable. There is a sudden drop in both blood pressure and heart rate associated with fainting, syncope, loss of consciousness. And then when the patient is returned to supine position, you see the vital signs are normalized. And the last common pattern is postural tachycardia syndrome. Blood pressure is in blue, heart rate is in pink. You see the blood pressure is holding when the patient is tilted. But for some reason, heart rate continues to rise above 120, often higher. And it stays that way while the patient is very symptomatic during this time. When they are returned to supine position, vital signs gradually normalize. The diagnostic criteria for common autonomic disorders presented here, and we just saw these patterns for POTS. The one criteria is an increase in heart rate of at least 30 beats per minute or an absolute heart rate of at least 120 beats per minute within 10 minutes of a tilt-table test or stand test. The second criteria is that orthostatic blood pressure remains unchanged. And the third one, very important, symptoms of presyncope and orthostatic intolerance need to happen, not only on the tilt-table test, but also for 6 months. This is a chronic disorder. In neurocardiogenic syncope, there is an abrupt loss of consciousness and a sudden fall in blood pressure and heart rate and cerebral hypoperfusion. Most of the time, this is an episodic disorder. It comes and goes. In between the episodes, a lot of patients are usually normal. They don't experience orthostatic intolerance, and sometimes they do, but in the majority of cases, this is an episodic disorder. Orthostatic hypotension requires a drop in blood pressure by 20 millimeters of mercury systolic or 10 millimeters of mercury diastolic within 3 minutes of a tilt-table test. In the next few slides, I will concentrate on POTS since it's one of the most common autonomic disorders in clinical practice that I know many of you are seeing in your clinic, ER or hospital floors. I know you're seeing these patients because I am sharing them with physicians and healthcare providers of all specialties. Symptoms of POTS are many and cover multiple organ systems and physiologic domains. The key is to recognize what you're dealing with. It can be overwhelming because the patients are presenting with all kinds of non-specific symptoms. You can't make sense. But if you're on the lookout and know what you're looking for, you can create a pattern in your mind, and obviously with that you can test them for these disorders. So symptoms of cerebral hypoperfusion are your lightheadedness, weakness of the legs, difficulty concentrating, generalized weakness. And symptoms of sympathetic overactivity are tachycardia, tremulousness, chest pain, vasomotor symptoms, and autonomic storms. And these autonomic storms resemble a big panic attack, except it's not. The heart rate and blood pressure both can be elevated during this. The patient may feel hot and anxious and flushed. There may be also polyuria during these episodes. They come and go spontaneously. These are not uncommon in our patients. And then we have associated manifestations of autonomic instability, which is a migraine headache, very common comorbidity, GI disorders, and others. POTS rarely exists in isolation and often carries with itself a number of important comorbidities. Small fiber neuropathy is very common. Migraine headache. At least a third of our patients, 25 to 30%, they have Ehlers-Danlos syndrome or joint hypermobility. We'll talk about that in a few minutes. It's usually a hereditary disorder of collagen. Autoimmune disorders impact at least 20% of our patients, with the most common being Hashimoto's thyroiditis, but there are all others autoimmunity, including antiphospholipid syndrome. Mast cell activation syndrome, we'll talk about that, also happens in at least 20% of our patients. And then we have unknown number of our patients with immunologic dysfunction, impaired metabolism, energy production, and variability in genetics, in epigenetics for NET transporter, norepinephrine transporter, very important in our field. And there may be mitochondrial dysfunction that's not yet clearly defined, because the field of mitochondrial disorders is always very much evolving with new mutations identified all the time. Years ago, I received a grant to study autoimmune markers and autoimmune disorders in patients with POTS. Can you hear me? Okay.
Yes.
Okay.
Yes.
Okay. I think there is a sound from somewhere. I'm not sure if it's me or someone. Okay. And so I noticed that a significant number of my POTS patients have positive markers of autoimmunity and comorbid autoimmune disorders. When we applied statistical analysis, we found that POTS patients had a higher prevalence of ANA, anti-nuclear antibody, 25% had them, and other autoimmune markers. And these are your antiphospholipid antibodies and other elevated markers of autoimmunity than general population. Okay, so as you see, it's statistically significant. As you see from this chart, the prevalence of most defined autoimmune conditions was higher in my cohort of 100 patients with POTS than in general population, with any type of autoimmune disorder affecting 1 in 5 patients with POTS, any type, and Hashimoto's thyroiditis here being the most prevalent, affecting 11% of our patients. Quarter of our patients had positive ANA. There has been significant research interest in the past few years to investigate whether POTS is in of itself an autoimmune disorder. And while we have not conclusively answered this question yet, it appears that POTS may have a strong autoimmune basis. As you can see from the slide, various antibodies have been discovered in patients with POTS. These antibodies are critical to the structure and function of the sympathetic and parasympathetic nervous system. So it makes sense that these antibodies would be potential biomarkers in this disorder. Last year, we've had significant progress when an animal model was introduced by Dr. David Kemp from the University of Oklahoma. He immunized rabbits with adrenergic receptor peptide and simulated POTS in rabbits. All these findings are undoubtedly important and have therapeutic implications in immunotherapy. We're already using some of these therapies in selected patients with POTS quite effectively, actually. Treatment of POTS includes non-pharmacologic measures and pharmacotherapy. I want to emphasize we always recommend for the patients to drink at least 2 liters of fluids per day and to consume significant amount of salt, sodium chloride, 5 to 7 grams per day. That's a lot of salt, so we always recommend to use salt tablets. You can get them in the pharmacy or on Amazon, in addition to dietary salt. We also recommend waist-high compression stockings that vasoconstrict and prevent blood pooling. Recumbent exercise are very important because the patients still need to have good muscle mass in the legs as a very good pump to get the blood back up to the heart. And lifestyle changes in avoiding various triggers like prolonged standing, being out in the heat, taking a hot shower, or, you know, stuff like jacuzzi isn't very good for our patients. They learn to cope very well. Biofeedback and diet can also be important here with non-pharmacologic therapy. In the pharmacotherapy, we use first-line medication treatment options, which are your beta blockers, fludrocortisone, midodrine, pyridoxystimin. We also have other medications available to us in our toolbox, ivabradine to decrease heart rate, clonidine. We have stimulants. We also use antihistamines because they can be very helpful here. Neuropathic pain medications, we use headache medications, anti-nausea medications. Sometimes SSRIs are very useful in some patients, but not all. A lot of our patients do not tolerate SSRIs very well. Benzodiazepines can be very effective. Of course, we try not to resort to chronic benzodiazepine use unless it's absolutely necessary. And droxidopa has been recently FDA approved for treatment of neurogenic orthostatic hypotension. We have other therapies that are emerging: IVIG, subcutaneous IgG, Plaquenil as immunomodulatory. Sometimes steroids have to be used when there is autoimmune component. Plasmapheresis can be sometimes effective. IV fluids, a lot of our patients love IV fluids. We'll talk about that more. We can use them as needed. Right now, there are ongoing trials of non-invasive vagus nerve stimulator for treatment of POTS, for treatment of small fiber neuropathy and gastroparesis. And we're hoping that it becomes effective and accessible to our patients because many of them cannot tolerate oral medications very well. Occasionally, an exercise protocol that's very intense called Levine's protocol has been very helpful. CBT, cognitive behavioral therapy, can be helpful, but not in most patients. And we'll move quickly because I have a few more slides to go. on POTS prognosis is, despite the notion that POTS has good prognosis, it has to be emphasized that less than 20% of pediatric POTS patients fully recover, less than 20%. This is a significant financial and psychological burden for the affected individuals and their families. At least 25% of our patients are unable to work or attend school, and the disability in POTS is comparable to COPD and CHF. Although 50% of patients improve over time, for most patients, POTS is a chronic disabling condition that can fluctuate in severity from year to year. Since POTS predominantly affects women of childbearing age, the question of how pregnancy factors into this disease course was very important, especially because pregnancy is one of the triggers of POTS. And years ago, to understand the relationship between POTS and pregnancy, we conducted a study here in collaboration with the Department of OBGYN at UB. We found that 60% of patients actually remain stable during pregnancy. And following pregnancy, 50% are still doing okay. And 40% felt worse during pregnancy compared to pre-pregnancy level, and 50% were also feeling worse. So it's a mixed bag. In that study, hyperemesis was the most common pregnancy complication, and there was also an increased number of miscarriages than in general population. But most women had normal vaginal deliveries without significant complications. I'll quickly go through common presentation of POTS that you see in your clinical practice. So think of POTS in a patient who presents with post-infectious onset of dizziness, fatigue, orthostatic intolerance, syncope, presyncope, and brain fog. Post-viral onset is very common. This is actually a photo without, showing his face. This is a photo of a young physician from New York City who developed POTS after COVID-19. Here you see him doing a self-administered stand test. He was healthy before, was unable to return to work on time. Fortunately, he recovered after a few weeks. It took him a while, but he's back to work. So post-infectious onset, and now we might be seeing post-coronavirus patients as well. Also, another common presentation is anyone with small fiber neuropathy, as we mentioned previously. When you have a patient with post-concussive syndrome and their symptoms are not resolving, you see them complain of dizziness, fluctuating heart rate, blood pressure, they have headaches, sleep disturbance, they're not recovering, think of dysautonomia or POTS, because concussion is a known trigger. Another common presentation is a patient with severe headaches that are intractable. They are very dizzy and fatigued. And when you treat their POTS symptoms, their headaches may also improve. Vice versa, when you treat their headaches, they may improve somewhat. Post-operative presentation of POTS is also very common after minor surgical procedures, like a wisdom teeth extraction, for example. Postpartum is another common presentation, and these are women who have difficulty taking care of their baby due to dizziness, fatigue, tachycardia, syncope, presyncope. There may be additional diagnosis of postpartum anxiety or depression, but look for physical features, because if you only treat postpartum anxiety or depression with SSRIs, they may not necessarily improve. A lot of them actually feel worse because a lot of our patients do not tolerate SSRIs well. In the remaining minutes, I'll talk about some other common disorders that overlap with our area. Ehlers-Danlos syndrome is a hereditary connective tissue disorder, most commonly of collagen. And these people present as teens or young adults with chronic joint pain, with frequent joint dislocations, easy bruising, stretch marks, IBS, a host of other symptoms, dizziness, palpitations. Think of Ehlers-Danlos syndrome. You assess it by Beighton score or refer them to a geneticist in our area. And Ehlers-Danlos patients can have Chiari type 1 malformation. They can have tethered cord syndrome and craniocervical instability. We got to think of these very important neurologic complications. In neurology, these patients are at a higher risk of both spontaneous CSF leaks due to abnormal collagen in the dura. They can also have idiopathic intracranial hypertension, so quite complicated. About 20% of patients have mast cells. Here you see a mast cell. It's a cell that's very important in the allergic and immune response. When the cell is in contact with a trigger, whether environmental or medication or food, it degranulates. When it degranulates, it releases histamine, tryptase, leukotrienes, cytokines, growth factors. These patients are always reporting severe, significant reactions and sensitivities to just about everything under the sun: food, environment, medications, dyes. They have a history of asthma and allergies, and they can have dysautonomia. So treatment with antihistamines often improves their symptoms, including mast cell-mediated headaches. We're almost at the end. It's important to recognize that dysautonomia is very complex and full of nuance. Every patient presents with a specific set of symptoms, and no two patients are alike. Having said that, certain trends emerge clinically, which I'd like to share with you today. First, always do orthostatic blood pressure and heart rate in suspected cases. Second, vital signs can normalize with treatment, but the patients can still be sick with fatigue, dizziness, and other symptoms. This is because, as I mentioned previously, symptoms of cerebral hypoperfusion often persist despite artificially correcting blood pressure and heart rate with medications. Get a tilt table test for unexplained spells or loss of consciousness. Get a tilt table test for someone with chronic dizziness and chronic fatigue. When they have headaches and palpitations and different episodes of weakness that doesn't add up, these episodes don't end up to anything, get a tilt table test. And treat comorbid conditions like migraine, joint pain, insomnia, mood disorders if present. And you can give IV saline in the ER. If these patients present to you decompensated to the emergency room, give them a bolus of saline. They respond very well. And last slide is going to be on myth busters. I'd like to mention some of them to break certain misconceptions that exist in medical community about dysautonomia. Recently, I was invited to speak at the Heart Rhythm Society conference, which is the largest meeting of the cardiologists and electrophysiologists. I was given a topic of dysautonomia from a neurologist perspective and presented the slide there. Number one, dysautonomia is not caused by anxiety, but anxiety can be a symptom, just like anxiety can be a symptom of hyperthyroidism. Dysautonomia POTS are not caused by deconditioning, but as you can imagine, in patients with exercise intolerance, which are our patients, deconditioning is very common and is secondary to the disease process. One of my colleagues asked me if dysautonomia is functional neurologic disorder or conversion. It's not. SSRIs are not the first choice of treatment. Beta blockers, Florinef, Midodrine, Mestinon are. Start the patients on low dose and slowly increase to maximum therapeutic effect. And last point is that we always recommend oral fluids, but sometimes they're not as helpful, and the patient can drink a lot of fluids and eat a lot of salt. They're still feeling very sick, decompensated. You can give them IV saline 1 to 2 liters sometimes. And sometimes IV saline works so well that the patient now wants it all the time, daily, chronically. We try not to go to the route of chronic saline use, because then you need to think about permanent line placement, and that has risks of infection and clots. So use IV saline sparingly during flare-ups. It can be very helpful. So I will finish with this cartoon that's relevant to the current times. It's also a good representation of dysautonomia and the relationship between the brain and the heart. Once again, thank you, Dr. Sami, for inviting me. I hope I was able to provide some valuable information today that will help you diagnose and treat patients with autonomic disorders. Thank you.